Hi, I'm Kristen Marks, a researcher and clinician at Weill Cornell Medical College. I conduct clinical trials related to hepatitis C in HIV-infected persons, and I provide care at our HIV and hepatitis clinics. This mini lecture will be focused on the principles learned from hepatitis C genotype 1 treatment studies involving the use of boceprevir and tenofovir in patients without HIV infection. Before discussing the use of boceprevir and tenofovir, we will review the predictors of response to treatment with PegIFN and ribavirin alone. The most important predictor of response is the hepatitis C genotype, with genotype 1 being the most common in the United States, but also the hardest to treat. Both boceprevir and tenofovir have activity against genotype 1, and the use of these drugs for the treatment of genotype 1 will be the subject for the rest of this lecture. Other predictors include HCV RNA level, HIV status, adherence to treatment, and race or genetic background. Particularly a genetic polymorphism mapping to the IL-28B gene. Age, body weight, fibrosis stage, and insulin sensitivity are other predictors. Since PegIFN and ribavirin treatment fails most patients with genotype 1 infection, agents that directly target the steps of the HCV viral life cycle have been developed. Boceprevir and tenofovir, the first two FDA-approved direct-acting antiviral drugs, inhibit the hepatitis C protease enzyme. Other protease inhibitors, as well as agents from other drug classes targeting different steps in the hepatitis C life cycle, are also in development. I will briefly review the phase 3 data for the use of boceprevir and tenofovir that led to the approval of these drugs in treatment-naive patients. In Illuminate, 72% of patients with hepatitis C genotype 1 had a sustained virologic response, defined as suppression of virus for 24 weeks after completion of hepatitis C treatment, with a regimen containing tenofovir plus PegIFN and ribavirin. This study proved that subjects without cirrhosis who have a rapid response to treatment can shorten treatment duration from 48 to 24 weeks without compromising the SVR rate. Advance demonstrated the superiority of tenofovir plus PegIFN and ribavirin over PegIFN and ribavirin alone. While Sprint 2 established that a regimen containing boceprevir plus PegIFN and ribavirin was superior to PegIFN and ribavirin alone. Both of these studies showed that the addition of protease inhibitors resulted in approximately 30% higher SVR rates than PegIFN and ribavirin alone. The study regimens used are also listed in this slide. As you can see, different treatment strategies are employed for boceprevir and tenofovir. With boceprevir, a 4-week lead-in with PegIFN and ribavirin is given prior to initiating boceprevir, whereas with tenofovir, all 3 drugs are started simultaneously. A simulation exercise follows this didactic. It will familiarize you with these regimens and the recommended algorithms for their use. With the addition of a protease inhibitor to PegIFN and ribavirin, many of the traditional predictors of response shown in the first slide become less significant. The data shown here, demonstrated in the red squares, that baseline viral load is a much less significant predictor of response when tenofovir is added to PegIFN and ribavirin. Another important principle to understand is that of response-guided therapy. When treating treatment-naive patients and relapsers without cirrhosis, treatment can be shortened in patients who rapidly suppress HCV RNA to below detection. This slide demonstrates that for treatment-naive patients who achieved undetectable HCV RNA by 4 weeks into tenofovir-based treatment and remained suppressed through 12 weeks, shortening therapy did not affect the SVR rates. Moreover, 65% of patients were eligible for shortened therapy in this study. For patients who have previously been treated with PegIFN and ribavirin but not cured, prior treatment response is the most important predictor of successful treatment with protease inhibitor-based therapy. Patients are characterized into the following categories of prior non-response: null response, partial response, and relapse. Null response, shown in red, is defined as less than 2 log drop by week 12 of treatment. Partial response, shown in pink, is defined as greater than or equal to 2 log drop by week 12, but not achieving undetectable HCV RNA by week 24. And relapse, shown in blue, is defined as undetectable on treatment, but recurrence of HCV RNA after treatment is stopped. This study of the use of tenofovir in addition to PegIFN and ribavirin in treatment-experienced patients demonstrates this point. It shows that the best response occurs in relapsers, followed by partial responders, and then null responders. Similarly, studies of boceprevir in treatment-experienced patients also show the patients with most responsiveness to PEG interferon and ribavirin during their treatment course do the best with the addition of the protease inhibitor. In boceprevir studies, the viral decline observed during the PEG interferon ribavirin lead-in phase may also be used as a measure of interferon responsiveness. The magnitude of the response during this phase also predicts the likelihood of SVR. The addition of a third drug improves response rates but also increases the frequency of side effects. This slide shows side effects in the phase 3 treatment-naive studies that occurred at least 10% more often in the protease inhibitor group. Rash, including serious cutaneous reactions, is an important side effect to be aware of with telaprevir use. The product information contains a detailed rash management plan that should be immediately referred to in event of rash to help determine the severity and whether to continue the medications. Other side effects of telaprevir include pruritus and anorectal complaints. Both telaprevir and boceprevir are also associated with an incremental increase in anemia over PEG interferon and ribavirin alone. Boceprevir additionally has been associated with dysgeusia or altered taste. Patients with advanced fibrosis or cirrhosis are in urgent need of treatment to prevent progression to decompensated liver disease or liver cancer. However, these patients are also most at risk for complications during treatment. This slide shows that hematologic side effects and infection occur quite frequently by week 16 of treatment when null responders with cirrhosis receive telaprevir or boceprevir-based therapy. Less frequent, but of greatest concern, were the deaths and hepatic decompensations observed in this study. Predictors of these severe complications include thrombocytopenia and low albumin, markers of more advanced liver disease. This underscores the need for careful consideration of patients' appropriateness for treatment. And if a patient with cirrhosis is deemed a candidate for treatment, close monitoring during treatment is required. Boceprevir and telaprevir are both inducers and substrate of the CYP3A4 enzymes, so drug interactions are common. Interactions with statins, antiarrhythmics, oral contraceptives, and antiretrovirals are of particular concern given their frequent use. There are too many interactions to list here, so check the package insert and drug interaction software as well. A useful self-study module that focuses on drug interaction with hepatitis C protease inhibitors can be found on the New York, New Jersey AETC website. Other lessons that have been learned with boceprevir and telaprevir-based treatments are listed on this slide. Advanced fibrosis predicts poorer response. Genotype 1b has a higher barrier to resistance than genotype 1a. And stopping rules for treatment futility differ from PEG interferon and ribavirin. These will be covered during the simulation exercise. In addition, mutations conferring resistance are selected out during virologic failure on treatment. However, the impact of these mutations on future treatments remains to be determined. Another important lesson learned was that anemia management by dose reduction did not appear to reduce SVR rates in randomized controlled studies of boceprevir-based therapy. Next, you will work through a simulation exercise reviewing the algorithms for response-guided therapy.